already distant metastasis is quite high. So in terms of biology, again, it's very important to differentiate these two types of locally advanced and inflammatory breast cancer. So, but even for, let's call the locally advanced breast cancer the most common type, even for those, more than half are grade 3. But also the great majority is ER-positive disease. And so this is very important in terms of management. The percentage of HER2 positivity, it's not different from the non-locally advanced breast cancer. And so, and for inflammatory breast cancer, most of it are grade 3. They have a high proliferative rate, but they are still, in the majority of cases, ER-positive disease. And again, please keep this in mind because it is important. So it is important also to realize that this disease, as the majority of breast cancers, is a systemic disease from the beginning, from the diagnosis. And so before the introduction of systemic chemotherapy, the mortality rates were extremely high. So more than 80% at 10 years for locally advanced and more than 90% for inflammatory breast cancer. And it's very important. It is important for all breast cancer types, but it is extremely important to have a multidisciplinary team taking the decision for these patients. It is usually necessary to have a combined modality with the three main specialties, surgery, radiotherapy, and medical oncology. And it's important to choose the best sequence for the individual patient. This is why it's so crucial to discuss the case from the beginning in a multidisciplinary team. So focusing now on the neoadjuvant or primary systemic therapy, the potential advantages is, of course, the downstaging of the large tumor. It can make a non-operable tumor become operable, and also it can make breast-conserving surgery possible in cases where only a mastectomy would be the solution. Of course, here it will depend on your national availability, because if you are going for a breast-conserving surgery, you need to know that radiotherapy is mandatory. So if you have available radiotherapy, then it's worthwhile to try to downstage a tumor and to make a less aggressive surgery for the woman. And you have seen a very, very interesting quotes of women who would like to keep their body intact. And of course, this implies the availability of radiotherapy, so that only you can know if in your area radiotherapy is available, and if so, it's worthwhile to downstage a tumor and go for breast-conserving surgery. It is also said that neoadjuvant systemic therapy will allow you an in vivo assessment of the efficacy of therapy, and this is true. What is not less true, but less known how to do is the guide for therapy selection. We still don't know, and I'll give you examples, exactly what to do in terms of the follow-up of the type of treatment to give. Something important is that if you start with a systemic therapy, you have no delay in treating a disease that is systemic, and this is particularly important for inflammatory breast cancer. And as we already spoke a little bit, it's also a very good model for translational research. The potential disadvantages is that you lose a little bit the accuracy of axillary staging, because you only have clinical, eventually ultrasound, but this might be important or might be less important, but it is one of the potential disadvantages. There is also the fear that you delay local regional control, and this is particularly important for patients who do not respond. And this is something that we can then further on discuss, but for those patients who do not respond to your best chemotherapy, don't insist too much. If you can, you give endocrine therapy, but don't lose the potential of operable disease. Sometimes we try to give more systemic therapy, and then the disease becomes inoperable. So this is a difficult balance, but we have to keep this in mind. Then there was two other disadvantages that I do not myself consider very important, but some people pointed out, like the increased risk of complications from surgery and radiotherapy, and the potential to induce drug resistance. there are a lot of challenges around neoadjuvant therapy all over the world. We still don't know what is the best method to assess response and so to evaluate efficacy. Is it clinically enough? Ultrasound, does it help? Should we do anything else? Of course, in countries where you have everything available, you can discuss things like MRI, but this is not the point here. So we still don't know how to best assess the response. Also, there are discussions on what is the optimal local regional therapy after a neoadjuvant systemic therapy. Should you offer always mastectomy? Should you offer always radiotherapy? These are questions still open. And also, when should you perform your pathology? And particularly when you have limited resources and you cannot perform pathology before and after, what is the best timing? So what is the best pathology assessment before any treatment or the residual disease, what type of residual disease it exists? These are questions that are still open all over the world, and I do not have answers for all of them, of course. So in terms of general recommendations for chemotherapy and in terms of agents, for locally advanced breast cancer, the minimum recommendation is 4 cycles or 12 weeks of treatment. And mostly appropriate, and if you have access to it, would be anthracycline-based chemotherapy. And this would allow to have 60 to 90% tumor regressions and up until 10% of pathological complete response. There are studies studying the addition of other agents, such as taxanes. There's a lot of discussion about taxanes, and taxanes are an expensive drug, and I will show you that it might not be the best way to spend our money, particularly if we don't have a lot of money. But so there are some studies showing that if you add other agents, you could increase the response rate to 90% and the pathological complete response to up to 20-30%. So the medium duration of treatment, it is about 12 weeks because, as you can see, to achieve a partial response, you need at least 9 weeks, and for a complete response, around 12 to 15 weeks. So when neoadjuvant therapy started to be used, some questions came out. So would it have any negative effect in disease-free and overall survival? Would it have any negative effect in local recurrence? And what will be the prognostic value of achieving a pathological complete response? It's very difficult to show you results of studies because the studies are very heterogeneous, probably because the disease is also very heterogeneous. But in some studies, inflammatory breast cancer was allowed. In others, it was not. In some, operable locally advanced was mixed with inoperable locally advanced. So there is an heterogeneity of disease that it's difficult. I will just show you 3 studies. I will just show you 3 studies and the main messages from these studies, because these are considered landmark trials that have helped us shape this type of treatment. This, to answer to the first question, is there any harm in starting with systemic treatment? And you can see here the majority of studies that compare adjuvant with neoadjuvant show that there is no difference in overall survival and no difference in disease-free survival. And so you do no harm by delaying surgery. And this, in terms of including the beliefs of the patients, it's very important. Also the beliefs of some healthcare providers. Delaying surgery does not do any harm. And so this is an important message. And this is just a meta-analysis published a few years ago showing the same thing, taking all the studies and showing that there is no harm in terms of long-term outcomes, perhaps a very small increase in the risk of local regional recurrence. And we also learn a lot from the early breast cancer trials cooperative overview, and you can see the same thing. You have less mastectomies, you have the same long-term outcomes, and particularly by year 10, and you know that breast cancer is a very long-term disease,